Well, this is an area where, at least for hypothyroidism, I think most pediatricians I talk to seem a little bit more comfortable than certainly calcium disorders. But let's see how you do. We're going to sort of talk about some of the common issues because thyroid diseases are common in kids. While some of the signs and symptoms of thyroid dysfunction are similar, there's some important differences between adults and children we'll talk a little bit about. And then one of the things that's critically important in children is in a hypothyroid state, it can devastate not only development if it's early enough, but linear growth if it's anywhere along the continuum of growth. And most pediatricians are quite good about maintaining a good growth record. So the feedback loop starts in the brain with the hypothalamus stimulating the pituitary to release TSH, or thyroid stimulating hormone, and then it interacts with the thyroid gland to release T4. T4 actually gets converted to T3, which is the active product, and it gets degraded into T3, T2, and then recycles the protein and the iodine. So let's start off with a case, because that's what you guys are going to be seeing in your offices and also examinations. This is a 12-year-old girl who has a history of decreased linear growth, dry skin, pale complexion, and constipation. Her appetite, sleep habits, and physical activities are otherwise normal. She recently developed tender stage 2 breast, but no axillary hair or pubic hair, and she denies any vaginal discharge or bleeding. So which of the following is most likely to be present on physical examination? So taking into account her history, I would suggest to you that at 12 years of age with tender stage 2 breast, she's a little delayed in terms of sexual maturation. And she's got decreased linear growth, dry skin, pale complexion, and constipation. So of these choices, what would be your choice? Goiter. Now, how many of you are comfortable feeling the neck for a thyroid enlargement? How many of you actually know where the thyroid is? Okay. Well, let me suggest this to you. Get in the habit of feeling the thyroid however you do it on all your kids, even preemies. It's a one-finger exam, because when the question comes up, does this kid have a thyroid enlargement or a nodule, you need to be comfortable with what the normal thyroid feels like as a baseline. And you got kids cranking through your clinic all day long. It's a free exam, right? Okay. So goiter. This is what a goiter looks like. Just simply an enlargement of the thyroid gland. Now that being said, sometimes when you say things in front of parents that they've not heard before or they misinterpret, when you say goiter, they interpret that as cancer. So be sure you explain yourself when you use these kind of terms. It can be frightening to people. So based on your examination, which of the following tests would be the most informative, given the kid's history? What are you going to do next? Again, this child's insurance companies are going to require one blood test their whole life. So we're not asking about bowed legs, we're asking about a goiter, thyroid enlargement. So here, the test of interest is going to be, let's have a little commitment here, people. There you go, very good. Now, let's talk about what a thyroid scan and thyroid uptake are. Okay, a thyroid scan actually provides an image. So if you want to see a picture of the thyroid gland, you ask for a thyroid scan. It's going to give you a visual image. So if you want to know where it is, the size of it, whether you have a nodule, whether it's present or not, then you can do a scan. By the way, you can do most of those things on physical examination without doing a scan. So we do very few scans. On the other hand, if you want to, so this is what a scan looks like. The one to the left is normal, looks like a butterfly or bow tie. Okay, it's that little stippling is because this is done with nuclear medicine techniques. The one to your right is actually there. The thyroid gland is actually eaten up by lymphocytes. So this is a kid with Hashimoto's disease. The way these things are done is they put little markers in the sternal notch and along the sternocleidomastoids so you can find the image. But that gland is pretty much dissolved by lymphocytic reabsorption. So it has that salt and pepper kind of appearance. An uptake, by contrast, and you'll hear people misuse these terms all the time, an uptake is actually a functional test. What happens is you give a dose of iodine to a patient, and within 6 hours usually, and then again at 24 hours, you measure how much of that iodine wound up in the thyroid gland. By the way, the human body only does one thing with iodine, and that is makes thyroid hormone. That's it. That's all it does. So we take advantage of that. So we give 100%, whatever the dose is, it's 100% that was administered to you. And in 24 hours, we would expect normally it ought to be somewhere between 15 to 20%. Here's the fun part. If you're hyperthyroid, do you think that number is going to go up or down? Well, in a hyperthyroid patient, my guess is you're going to be sucking a lot more iodine in there to make more thyroid hormone, so it's going to be elevated. In a hypothyroid patient, it's going to go down. Okay, so again, this is pretty intuitive. But just keep in mind, if you want to order some visual look at the gland, you go get a scan. If you want to do a functional test, if you're thinking the patient's got hyperthyroidism, for example, and there may be occasion to do this, you can do an uptake study. So primary hypothyroidism is going to have a low T4 total or free, and then an elevated TSH. Secondary or tertiary, meaning now the pituitary is the secondary or the hypothalamus being the tertiary. The brain's not producing, in the case of hypothyroidism, the brain's not producing TSH, so there's no signal to the thyroid gland. So the T4 is going to be low, but it's a downstream effect. When should a total and or free T3 be obtained in a patient suspected of hypothyroidism? So what I'm trying to tell you is that there are very few, if any, occasions that a pediatrician in particular would order a free T3 or even a total T3. And we see it all the time. So the typical referral is going to be a scan, an uptake, a free T4, a free T3, a TSH, and God knows what else. We don't need all that information. You're just wasting money. Okay? Plus, sometimes those numbers are abnormal, and the patients or parents are fixed on that, and I don't have a clue what it means. But it's irrelevant to the diagnosis and treatment. But there are very few, if any, circumstances that I can think of that as a pediatrician you would order anything related to a T3. So if anything on that lab request has T3 in it, don't do it. Sorry? All right, so in Victoria's case, which of the following tests would be the most helpful in determining the cause of her goiter and her elevated TSH? So what are we thinking? Here what we want you to do is sort of think, well, let's think about what the diagnosis is and work backwards, right? We're trying to prove a diagnosis. What are we looking for? Hashimoto's disease. Why? One, because it's common. Two, because she's female, right? So thyroid diseases are going to be much more common in females, even in children. And it's pretty easy to get the thyroid antibodies because that's how we make the diagnosis, right? I mean, theoretically, we ought to biopsy the gland, but we don't usually go to that extreme. So thyroid antibodies. So what's the most likely diagnosis here? Yeah, chronic lymphocytic thyroiditis or Hashimoto's disease. So hypothyroidism causes a decreased production of thyroid hormones. In response, you get a compensatory increase in TSH. On the other hand, if the pituitary or hypothalamus is not producing their signal, you're just going to have a downstream lack of thyroid hormone because there's no signal, right? You don't have any electricity coming into the building, the light switch is not going to work. Not because the light's burned out, there's no electricity coming in the building. This is a little blurred image of that same thing. It's just a feedback loop. So virtually all the endocrine system, as we just talked about with calcium disorders, works on a feedback loop, right? So as the thyroid hormone levels come up, the TSH levels will go down. As the thyroid levels go down, the TSH will go up. So that's why you get a range of normal values for both T4 and TSH. It's not a single number. In children, which of the following is the most common cause of acquired hypothyroidism? Acquired. Now, in case any of you were asleep during the first lecture, we talked about one concept called immunity, right? So when you see a test answer here that has anything to do with the immune system and you're in a fog, which one are you going to choose? Yeah, and you're going to get it about 80% of the time, you're going to be right. okay? So Hashimoto's thyroiditis is the most common cause of acquired hypothyroidism. It occurs more commonly in girls, usually 2 to 1, and it's very common in family members. Now, here's an important concept. If mom has hypothyroidism for Hashimoto's disease, you want to ask her what? Before you get to waxing and waning about her daughter, what do you want to know about mom? Sorry? You never ask women how old they are. I'd rather ask them how much they weigh. We'll talk about that during the obesity lecture, but what do you want to know? What you want to know is, tell me a little bit about your diagnosis. When were you diagnosed? Who else in your family has this? And how have you done with your hypothyroidism? Why is that critically important? Because adult women have all kind of issues. Sorry. They have all kind of issues with hypothyroidism. They can't get the dose right. They want to use naturopathic doses, whatever, okay? So the reason you get that on the table is you say, well, thank God your child is under 21 because we never have any problems with kids, girls or boys, with giving them thyroid hormone replacement for Hashimoto's. It's a very important concept in terms of your practice because that's a real entity, okay? Anybody had the same experience?